Hello everyone. Today we're going to talk about T-spine projections. Let's review the image analysis guidelines. For an AP T-spine, image analysis guidelines state that there should be uniform brightness across the entire thoracic vertebra. That means to use your anode heel effect as well as using the appropriate technical factors. Spinous processes should be aligned with the midline of the vertebral bodies. Distances from the vertebral column to the sternoclavicular ends and from the pedicles to the spinous processes are demonstrated equal on both sides. Intervertebral disc spaces should be open. The vertebral bodies are seen without distortion. This can be mitigated when the patient is supine and ensuring that you flex the patient's hips and knees until the lower back rests firmly against the imaging table. You should demonstrates the 7th thoracic vertebra at the center of the exposure field. That means your central ray should be directed to the mid-sagittal plane at a level halfway between the jugular notch and the xiphoid process. The 7th cervical vertebra, 1st through 12th thoracic vertebra, 1st lumbar vertebra, and 2.5 inches of the posterior ribs and mediastinum on each side of the vertebral column are included within the collimated field. We should transversely collimate to about 8 inches field of view, utilizing a lengthwise field of view of 17. Additionally, no more than 9 posterior ribs should be demonstrated above the diaphragm. This is resultant from us taking the exposure after a full inspiration. Take this exposure on a full suspended expiration. The next slide just gives you an overview of the image analysis guidelines that I provided for you. Again, we know that these image analysis guidelines are a little bit more extensive than what Merrill's provides you, but this is to help you be able to adequately critique your images. These are just little tips and tricks to help you. Please don't spend time committing all this information to memory, but use it as a guide. So let's talk about identifying vertebral rotation in an AP projection. In an AP thoracic projection, you can identify rotation by comparing the distances between the pedicles and the spinous processes on the same vertebra and the distances between the vertebral column and the medial ends of the clavicles. When no rotation is present, the comparable distances are equal. So the distances between the sternoclavicular ends the sternoclavicular ends should be equal, as well as the pedicles and the spinous processes. If one side demonstrates a longer distance, or one is foreshortened and one is elongated, there is vertebral rotation present. The side demonstrating a larger distance is the side of the patient positioned closer to the IR. In this projection, you can see that the left medial clavicular end is furthest further away from the vertebral column, which means that the left side is rotated down. The patient is in an LPO projection. So to correct this, you need to bring that mid-coronal plane parallel with the IR. Moving on, let's take a look at our first AP practice analysis of the thoracic vertebra. In this projection, you can see that the upper thoracic intervertebral disc spaces are actually closed, and the central ray was centered too inferiorly. It should have been centered at around T7. The central ray and upper thoracic disc spaces, were not parallel with the IR. So in order to correct this, we need to center the central ray between the jugular notch and the xiphoid process. Let's move on to our lateral T-spine projection. For the lateral T-spine projection, image analysis guidelines state that the intervertebral foramina should be clearly demonstrated. The pedicles should be in profile. The posterior surfaces of each vertebral body should be superimposed. No more than a ½ inch of space should be demonstrated between the posterior ribs. In order to achieve some of these guidelines we just talked about, you must ensure that the patient is positioned so that you place their shoulders, their posterior ribs, and the ASIS is directly on top of one another, aligning that mid-coronal plane perpendicular with the IR. Additional guidelines state that the humeri or the soft tissue are not seen obscuring the vertebra. The intervertebral disc spaces should be demonstrated as open. Vertebral bodies are demonstrated without distortion. The 7th thoracic vertebra should be demonstrated at the center of the exposure field. In order to achieve that centering, you need to center a perpendicular central ray to the inferior angles of the scapula, which is in line with T7. Additionally, the 12th thoracic vertebra, or the 12th thoracic vertebra, should be seen centered on the IR. Superimposition of the shoulders on the upper vertebra may cause underexposure in this area. The number of vertebra visualized depends on the size and shape of your patient, of course. So T1 to T3 may or may not be adequately visualized. And as you've seen previously, the image analysis guidelines are available to you on the PowerPoint. So let's talk about, on a lateral thoracic spine projection, how to determine rotation versus scoliosis. On a lateral projection with a patient in spinal scoliosis, it may look like there is some varying degrees of rotation. The posterior ribs will demonstrate differing degrees of separation depending on how severe the scoliosis. So there may be sections in the spine that there is superimposition or near superimposition, but then there's separation from maybe T6 down to T12. So the best way to confirm this is to view the AP thoracic projection, because like we say, one view is no view. So moving on from determining rotation versus scoliosis, let's talk about rotation in a lateral projection. It's very difficult to determine rotation in a lateral projection from which side of the patient was rotated anteriorly to posteriorly. However, if the patient was only slightly rotated one way, of determining which way the patient is rotated is to evaluate the amount of posterior rib superimposition here. As you can see, there's a very big amount of posterior rotation here. If the elevated side is rotated posteriorly, the posterior ribs demonstrate more than 1 inch of space between them. If the elevated side was rotated anteriorly, the posterior ribs are superimposed on a slight rotation and demonstrate greater separation as rotation of the patient increases. Another method to determining which way the patient is rotated is taking a look at their scapula and humeral heads when visible. So you can see the scapula here, which is greatly magnified. The scapula and humeral head demonstrating the greatest magnification will be the one sitting furthest away from the IR. So the side up is indicated here as, due to the magnification, as the right side rotated posteriorly. When we move on to there we go. And when we move on to the next image here, you can see this is indicative of a patient slightly rotated anteriorly. You can see that there is slight rotation here, but generally speaking, when a patient is rotated anteriorly, it's usually slight, and you'll see like differing, your intervertebral spaces will and foramina will be closed due to this rotation. And again, you'll be able to tell whether or not you're anterior or posterior from your humeral heads, which one is more anterior in relation to posterior. So let's take a look at this lateral practice analysis. As you can see in this image, the posterior ribs here demonstrate more than 1 inch of space between them. This is indicating to me, well, the right side or the side up probably was rotated posteriorly. In order to correct this, you need to make sure that that mid-coronal plane is perpendicular with the IR. Adjust those shoulders so that they are exactly one on top of another. Ensure that your ASISs are right on top of each other, making sure that the patient's hips are rotated anteriorly or posteriorly, because this all affects our imaging. That concludes part 1 of T-spine. I hope that you enjoyed this image analysis. Please stay tuned for part 2.